bunch of protocols prevent the life to fall. What, when, and how to use. It's your precious call.
To discuss more about it, I would like to call upon a stage Dr. Neeta Bose, Madam, to discuss regarding Montpellier protocol, preventing a Peri intubation arrest in the ICU, ED, and the OT. And I also request our chairperson to introduce our speaker.
Slide changer.
Good evening, everyone, and I hope that everyone is full of energy for the next talk. We have on the stage respected Dr. Neeta Bose, Madam. She is a professor and HOD of the anesthesia department in the GMERS Vadodara. He has done MD anesthesia, and post that she has done MBA in the hospital and the health management system. She has a numerous achievement, and she has been instructed for the ACLS, BCLS, CCLS, and ATLS. And she has been worked as a NABH assessor, MBA in the health and the hospital management. She has done numerous publications like 34 and the 6 chapters over the her curriculum and tenure. And she has been invited as a faculty and organized various CMEs, conferences, and workshops. An active member of the IA, ISA, ISCCM, and AIDAA. Now, area of interest of Madam is mainly basically USG, critical care, and the difficult airways. We welcome you, Madam Dr. Neeta Bose, and the stage is yours. Thank you.
Thank you for the nice introduction, and thank you organizers for having me here. And I think a very apt topic Anuj has given me. I think first I must say that this is, I'm talking about the Montpellier protocol for prevention of peri-intubation arrest in the ICU, ED, and the OT. What is this protocol basically? So this is something like a 10-point protocol. It has to be applied at the pre-intubation, during intubation, and the post-intubation phase in terms of using of the IV fluids, the pre-oxygenation, the rapid sequence intubation, all this, all in a bundle. So we are talking about that. This is a very common scene, worried when we are intubating in the ICU. You are trying, it's not getting in, you want to do something, and something else is going on. Can we play this slide, if possible? Back. Okay, so this kind of scenes we do see, you are struggling to intubate, you are trying to put the tube in, you don't have any new gadget, you go on, alone you are going on. So this is something like, I think it is very familiar, and then there may be bleeding, patient may vomit, and many things can happen. You can imagine rest of them. This is just a small, small clip. Okay, so this, basically the protocol came out from the Montpellier hospital in France, and there was an intervention to decrease the complications which are related to intubation in the ICUs, and it was a multicentric study basically. So basically, they were seeing whether it was done in some various ICUs, around 200 patients were taken, and all the intubations were, the consecutive intubations were taken into consideration. So how this protocol came into being is there was one control phase, there was a 4-week intervention phase, and again there was the 6 month the patient were studied after the protocol was put in. So there was a time buying period in the middle. So without the protocol, when the intubation were being performed, all the patient characteristic, the intubation, the drugs used, all that was noted, and what was being done, the data was shared, and on the basis of that, a protocol was made, and that was the Montpellier's protocol. And it was applied to all the resident nurses, etc. And then the recommended bundle was used to see whether there was any reduction in the mortality. Now let me tell you, when I am going through the protocol, you will feel, "Arey, ye to kya hai? This is a simple thing." But when you do it as a bundle, when you do not miss a step, that gives you a good outcome for the patient, right? So in the pre-intubation, it is said that there should be presence of 2 operators, must. If one cannot, the other one will, the one tires, the other one will take away. The fluid loading, that is isotonic saline to be given, especially in, you have to take care of the pulmonary edema, etc. Preparation of long-term sedation. Once you intubate, you need the tube inside. And pre-oxygenation with non-invasive positive pressure ventilation during and before, right? So you don't want to lose the PEEP effect. During intubation, it should be rapid sequence intubation. It has to be as fast as possible. You know the nitty-gritties of rapid sequence intubation. The Selix maneuver is important if you are considering the full stomach. Then post-intubation, confirmation always by capnography. This is one point which is actually needs to be done. It is missing many ICUs. And for every patient, it should be available. Now, how to do it? It can be done as your local protocols also. The norepinephrine, if diastolic pressure is going low, and initiating the long-term sedation and protective ventilation that we all know of, right? So these are what life-threatening events and less than life-threatening events which were noted were death, cardiac arrest, cardiovascular collapse, severe hypoxemia, and other mild complications like esophageal intubation, one-time hypotension. All these things were noted. Aspiration, arrhythmias, these all things can happen at the time of intubation of a patient in ICU. So it was found that in the protocol-guided group, when they did that 4-week intervention and again studied for the next 6 months, the protocols were adhered to in 75% cases, right? And there was differences between the two phases for 6 out of the 10 processes. I had mentioned those 10. So out of the 10, 6 processes were actually being followed. And NIPP was used in both the phases, right? What they found is, those are simple things. Remember, there are very simple things which I had enumerated. But when they used it as a bundle, there was a drop in the severe hypoxemia and severe hemodynamic collapse. Even the cardiac arrest incidence came down, but that was not significant. The other minor complications like esophageal intubation, difficult intubation, agitation, dental injury, all those things also do happen at the time of intubation. Those also came down. So it does make a difference. You can see it is significant. So complications reduced to 21 from 34%. In the esophageal intubations, they found that it was done without capnography, although they did not find any difference with or without capnography in both the groups, right? Rest of the other things, like the patient outcomes, like ICU ventilator-free days, length of stay, all that did not really matter. But what really mattered is the initial severe hypoxemia and the hemodynamic collapse that got avoided by following this intubation protocol. So now what is this thing? You need to have a checklist. If you are going to have a protocol, you need to have a checklist. You've got to follow it. Somebody has got to mark that you have done all the components of the protocol. And you know, we are so much checklist based. There are checklists in so many other scenarios also. Say for anesthesia analgesia, weaning from mechanical ventilation, surgical safety checklist, all these are already there and it is being used in practice. In previously, the observational studies before this protocol came in, they also found that complication was related to intubation in quite a number, 25 to 40% cases. So what it is recommended is, looking at the guidelines, you need to have a local care bundle in your ICU to suit to your ICU needs, right? So 6 of the 10 recommendations in this protocol was from the previous studies, that is the non-invasive ventilation, the rapid sequence intubation, the capnography, protective ventilation, etc. was done on the basis of the previous guidelines. And 4 of them, this particular study group, the Montpellier protocol group, they came out with some more 4 things. That is presence of 2 operators, scoline, Selix maneuver, capnography use, and protective ventilation, early vasopressor use. If you look into all these things, do you think we don't do any of this thing? We do. But we do it as a rescue measure. We don't do it as a protocol base. We have to do as a protocol base. We have to keep the things ready prior to intubation. Like if I know if the patient is hemodynamically stable, you start with the vasopressors. You give the fluid bolus. You don't wait for it to fall and then give the fluid bolus. So this is a 10-care bundle for management of intubation. And this decreased the severe hypoxemia and hemodynamic collapse in the first hour following intubation. Prior to the protocol actually came into being, this is from Montpellier Hospital in France, where they did, in 2006, they had done a survey or observational study to see what is the rate of complication during intubation, right? So they had done the study in the 7 French ICUs, and around 253 intubations were taken, and the complication and risk factors were noted down. The patient demographics, the procedure, for ETI procedure. So primary indication they found, it is usually respiratory failure, shock or coma, and significant ETI were performed by the residents. Most of it was by the junior people. So they found that respiratory failure, shock, and if a junior is supervised by senior, the outcomes would be better. And 28% were experiencing severe complications. There were other factors also, the SAP score, the older age, and etc. They were also there. In a prior study from where this all thing has stemmed also, they found that the airway management is because of the limitation in the physiologic reserve of the patient. So there will be likelihood of difficult masked ventilation, intubation, right? And you need to have all the armamentarium ready with you when you are doing the intubation, right? You cannot run for a thing which usually happens if a person remains alone there, right? So you can, now it is also said that you can include the video laryngoscopy for difficult intubation. Then you give the protective lung ventilation. You give the NIV during intubation also, right? So in case, if you are anticipating difficulty, you can go for awake fiber optic also. So this all prompted the research. And what it is said is, going ahead with this Montpellier protocol, there were several modifications after this, including certain more things. So how do you improve your knowledge? Is when you are trying to intubate a patient, you look at the MECOCA score. It's a simple score, whether this patient you are going to land up with difficulty or not. Using apneic oxygenation, that is HFNO, during the intubation. I will tell you how it works. And face mask ventilation after the RSI. So all these things need to be done as a bundle. And you can see down below that video laryngoscopes have also been creeping in this. This is the score. I'm not reading out to it. So if higher the score, more difficult. Another important thing, in obese patients, it is found that giving the head up improves the intubation process, the procedure. But if it is a non-obese, you can still do that. You can still give your patient a little bit head up. You will have a good view of the larynx, and you can intubate. It will be much easier. So it is said you get a head up position, 20 to 30 degrees. Remember one thing, when you are doing this, your logistics with the patient also has to match, right? That you cannot, it cannot be very higher up. And you also use, what they said is, you use the non-invasive ventilation during intubation, and when you are intubating and you have removed the NIV, you attach the HFNO, right? We put nasal prongs sometimes, but you can attach the HFNO, and that will give rise to apneic oxygenation, right? So this is how apneic oxygenation actually works. When you give a high flow oxygenation, the rate of oxygen which is dissociating inside is higher than what carbon dioxide comes in. So negative pressure is created, it pulls in more oxygen, right? So this is how it is working. And this is how video laryngoscopes will help. Remember, when you use your Macintosh, it's a direct line of the sight. When you use a video laryngoscope, your line of sight goes inside. Your eye actually goes inside for a better vision of the larynx. And that helps for intubation. You can see the video laryngoscopes. There are many. There is angulated, hyperangulated, ones with channel. So it gives the clearer vision. And you have to introduce it with the particular proper stillet. So these are the classification that I told of. These are various video laryngoscopes that you can see. And this is how you do it. This is the King Vision one. We see, and then we intubate. So your larynx is there, low, right in front of you. You have no problem. It is a good teaching tool also. And usually you require a stillet if it is a non-channeled one. So there are certain tips to improve your video laryngoscopy. Remember this, दिख रहा है मतलब intubate हो जाएगा, it's not like that. You need a learning curve for video laryngoscopes also. Right? So there is an airway management protocol where MACOCA score, use of video laryngoscopy, and stillet is also being recommended. The various drugs that we use, remember, etomidate is one of the good choice of drugs. We do not like propofol, which is a causes cardiovascular instability. This is another modified version of the Montpellier. Here, the video laryngoscope came in, and if you see the components, the operator's fluid, upright position, in a minute I'll finish. Right? So all the other components are there. So it is also said in COVID-19 this was very useful because intubation was very difficult. Healthcare workers had a big scare that they could get the infection. Out of bag mask and non-invasive is much better. In the modified, the stiletto trial, always intubate with the stillet in situ. It is always better. Why to take as a stillet later on, right? So this has been proven in the JAMA study from 29 countries, the Intube study. Another modified protocol where what they did is they put 10 points, they increased to 15 points, then they again decreased to 8 points, right? So there have been various modifications to this. I will go straight away to another modification. This is an equipment checklist where you have tick off the equipment. Bas in 30 seconds it will take. So equipment check, patient check, and the various adjuncts which you are using. Right? So I'm not going into all this. This is another revised bundle where they took only 6 components. Right? So you can choose your component according to the local protocols. Fine, I'll finish there because the rest of them are actually studies. So what the main gist has already been done. I'll finish. Don't worry. Okay, chalo. These are the few principles, and thank you very much for a patient here.